Good afternoon, one and all. At the outset, I would like to thank my professor, Dr. Devi Miral ma'am, my teachers and seniors for giving me this opportunity. For the next 30 minutes or so, we'll just have a look at a few nuclear medicine cases. So I think most of you would have come across this. In the recent days, radiology and nuclear medicine go hand in hand. Most of the cases, most of them are fusion images. So we get better anatomical information as well as the metabolic activity is picked up with the help of fusion. So here now we will look at both fusion imaging as well as the planar imaging. So that's the first image. It's a planar image here. So that is the history. So it's a case of road traffic accident followed by which the patient underwent T3, T10, stabilization, internal fixation, and laminectomies for decompression. Post-operative course was complicated with persistent right pleural effusion, which was positive for beta-2 transferrin. So what is the study? Beta-2 transferrin is, that's for CSF. So this is the questions will be identify the study and list out the findings. Identify the radio tracer which is going to be employed and enlist the normal imaging sequence of CSF hemodynamic study. So offer cysternogram and also to discuss the technique of CT cysternogram and indications. So this study is a radionuclide cysternography. So in this, So these are serial images which are taken over specific timing. So it will be taken over 2 to 6 hours, 12 hours, and 24 hours. So as it moves, this is the spine, this is the spinal subarachnoid space, which is seen taking up the radio tracer activity. And in the delayed images, there is still a small dot that you see over here. This is because of a CSF leak that is present. So the findings here is that the level of the previous lumbar puncture drain, there is a CSF leak which is picked up in the delayed images. So the radio tracer that is being used commonly is intrathecal indium 111 DTPA. This is because it can be, because of the half-life of this agent, and the serial imaging is usually done at 2 to 6 hours, 12 to 24 hours, and up to 72 hours. Radionuclide cysternography is mainly in cases where we have intermittent CSF leak. When there is an active CSF leak, it's better to go for a CT cysternogram or MR cysternography. So CT cysternogram, I think all of us will know this. It's just a lumbar puncture which has to be done, and the sample is collected, and 3 to 10 ml of iodinated non-ionic low osmolar contrast agent is injected, patient in head down position, and slowly this is maintained till it reaches the C-spine, and then patient is positioned horizontally, and other maneuvers like sneezing or Valsalva can be done to demonstrate the CSF leak. The indications of this scan, that is radionuclide cysternography, will be a localization of CSF leak and also an evaluation of hydrocephalus. So that is a procedure. The indium 111 DTPA is injected intrathecally via into the subarachnoid space. Cephalid migration is seen. Here it is seen the cephalid migration is injected over here and it's moving upwards. We'll see that it enters the basal cisterns by the first hour. So in the second hour image, you're able to see that it's entering the cisterns. And then it goes about into the ventricles. By 4 hours, you'll be having reflux into the ventricles. So this reflux is a normal finding, which will be present. And after that, it moves into the sylvian fissures and finally into the convexities. So that is the normal sequence of imaging. So there are 2 other images over here. This is a case of defect in the temporal region with a leak that is demonstrated here. And this is a case of normal pressure hydrocephalus. So the scenario can be given something like with the clinical features it can be given. And this is the axial image. Why is it the axial image? Because we have the anterior and posterior here as clues. And these are the anterior view, posterior view, and the lateral views. So in NPH, we will have a persistent reflux not just at 4 hours, but also at 24-hour delayed imaging. So we find the different signs. So on the anterior view, this is going to give the heart shape. On the posterior view, we'll have the butterfly shape, which is seen over here. And on the lateral views, we'll have the comma shape configuration in case of a normal pressure hydrocephalus. So the easier one over here is the PET-CT fusion imaging, which shows us the ventricles and the uptake in the sylvian fissures. Everything can be picked up much easy to pick it up with these images. So this is just a add-on to it. So this is how it's usually reported, the types of uptake in the cysternography. So there are about type 1, 2, 3A, 3B and 4. So coming to the next question. Yes. So this is something all of us are well versed with. So what is this scan? Yes, so this is once again, it's a clinical scenario where it's a 20-year-old female with hypopyrexia, tachycardia, and irregular menstrual cycles. Patient has undergone ultrasound screening of the neck, and this is the scan that's given. What is the finding? Is there a normal uptake? Was anything abnormal? All right, so the other questions are any two radiopharmaceuticals used, the clinical indications and conditions for increased and decreased uptake. So here, the findings in this case, this is the thyroid scintigraphy scan, and there is an uptake. This is a nodule which is seen over here. This is a dark colored structure over here. That's a hyperfunctioning solitary nodule of thyroid. The rest of the gland does not show any uptake, or there is no defect as such that's seen here. The radiopharmaceuticals, yes, Zestamib can be used. Usually these pharmaceuticals can be NIS specific and non-specific, that is sodium ion symporter specific and non-specific. The non-specific ones will be the FTG18 and iodine 123. Specific is mainly technetium 99, Zestamib. So these are the commonly used radiopharmaceuticals. Indications, again, for this scan is going to be to know the functional status of the thyroid nodule. Is it a hot nodule? Is it a cold nodule? And the differential diagnosis of thyrotoxicosis, as well as in cases of thyroid cancers to look for distant metastasis. Coming to the uptake, the gland will show a typical normal uptake in Hashimoto's. That is in the euthyroid status of Hashimoto's, it shows a normal uptake. Also following iodine 131 therapy, this shows a normal uptake. Increased uptake is going to be seen in Hashitoxicosis, that is the hyperthyroid state of Hashimoto's, and in Graves as well. Abnormal site of uptake, like we all know, it's going to be in ectopic as well as in lingual thyroid cases. And decreased uptake will be seen in subacute thyroiditis, struma ovariae, as well as Hashimoto's in the hypothyroid state of it. And in excess iodine uptake, we'll have decreased uptake in the gland. This is just another add-on. So thyroid scan as it is of two types. One is scintigraphy. Scintigraphy helps us to evaluate the nodules and the functional status. The other one is radioiodine thyroid uptake study. Now this is mainly to know the therapeutic activity of the radioiodine that is going to be given as a treatment dose in these patients. What do we assess by this? We will be able to know the iodine organification defects. So this has to be, we have to just have an idea about how the thyroid follicular cell functions and what is iodine organification. So if there is a defect, we have to mention that as well in certain cases. So this is how we can pick up the study. So this is just a normal, this is a display of the different findings. So here in cold nodule, we'll be having a defect. So you find that there's no uptake over here. This is a hot nodule that is seen. There are treatments which are used to assess any thyroid nodule. So that's the next question. I think we've already, ma'am has already discussed this question. So it's a 43-year-old woman presenting with the diagnosis of renal stones and elevated calcium levels. What scan is this? Yes, that's for the parathyroid. So the question is identify the scan, give the diagnosis, enumerate 3 indications again, and name the alternative radiotracers which can be used and the other radiological manifestations of this. So here we have serial images once again. So taking a closer look, we find that initially we find the butterfly shaped organ and there is an uptake that is seen over here. And in the delayed images, we find that there is just a single uptake that is seen. The butterfly shape is almost faded out. So what study is this? What type of scan is this? It's a single isotope dual phase imaging which is done. So initially the isotope has been taken up by the thyroid as well as the parathyroid. And in the delayed images, the thyroid uptake has diminished. We're able to see the persistently present superior parathyroid gland adenoma which is seen in this case. So the indications for this scan can be parathyroid adenoma. Other than parathyroid, this can be done, that is your Zestamib scan can be done for breast cancer to evaluate for myocardial perfusion scintigraphy as well. The alternative radio tracers for this condition will be thallium-201 scintigraphy as well as dual isotope subtraction technique which was already discussed. The other radiological features, I think all of us know we have subperiosteal resorptions, and then we have the radial side erosions, and we have acroosteolysis. We have Brown's tumor which can be present, so we have the lytic lesions here, and the pepper pot skull, which is typical of this condition. So that's the next question. This is a 50-year-old male presenting to the emergency department with complaints of persistent pain in the right hypochondrium for the past 6 months. Now the present complaints of the patient are fever, vomiting, nausea. So what is the finding that is seen here? Right, so that was a DCIDA scan that is taken, HIDA or DCIDA. Nowadays we use DCIDA or BRIDA scans because they have better hepatic extraction. So these are the commonly done. DCIDA scan is a better answer. So the findings here will be non-visualization of the gallbladder. So here we do not find this 30-minute, they're taken in different frames, and here we do not find the gallbladder at all. It is emptied into the bowel, and yet we don't find the gallbladder. So it is a case of acute cholecystitis that is seen. So what will be the next step? We'll go for imaging at 3 to 4 hours. So the alternative can be nowadays to restrict it. So at the end of 1 hour, if we don't find the GB, if we don't find the GB take any uptake, then we will wait for 3 to 4 hours to image. If you want to save time, and the better option will be to give a subanalgesic dose of morphine, and then once again image the patient in about 5 to 10 minutes. So this is going to contract the sphincters, and the gallbladder might be demonstrated. So this helps reduce the time from 4 hours to about 1.5 hours. So you'll wait till 1 hour for the normal uptake. If it does not, then you'll give morphine and complete the study by 30 minutes. So here this is post morphine injection. You find the GB showing the uptake here. The other indications, it's very simple. It's acute cholecystitis, chronic cholecystitis, biliary atresia, and bile leak. So in a case of biliary atresia, we will not have excretion to the bowel at 24 hours as well. So what can be done as a next step in this case, we can give phenobarbital to the patient, 5 milligram per kg per day for 5 days, and then we can repeat the scan in these patients. And two signs which are related to this condition. So very few studies have specific signs to them. So here we have to know two signs. One is cystic duct sign, that is the dilatation of the cystic duct secondary to obstruction. So this is going to be somewhere very close to the GB. So it should not be mistaken for gallbladder uptake. Another one is the rim sign, which is uptake in the region adjacent to the gallbladder. Why is rim sign important? This rim sign is a clue to identify complications like gangrene or perforation. So here in this image, there is an uptake that is seen over here at 3 hours. This is the cystic duct sign. So it is not exactly the GB that is showing the uptake. It is a dilated cystic duct which is showing the uptake. So this is the normal DCIDA scan which is seen over here. So we find the normal GB uptake that is imaged. In this case, anybody, what this could be? Is the radiotracer taking a normal course? Yeah, there is a bile leak over here. So we find there is a subdiaphragmatic bile leak in this case. And this is another case. Just look at the liver only. There is a increased uptake in certain areas of the liver. So this is a case of metastasis. This can also be imaged with a DCIDA scan, not just limited to the cholecystitis and gallbladder pathology. So coming to the next question. I think all of us are well versed with this scan. This is a ventilation perfusion scintigraphy. So here there's a 60-year-old male who presented to the OPD with progressive worsening and shortness of breath, rapid irregular heartbeat, fainting episodes, lightheadedness and cough was there. Chest X-ray was done, followed by this scan which was performed. So, so we know what this scan is, so we'll now identify this. We'll come to the radionuclides employed to perform this study. 2 conditions each for high and low VQ ratio, and 3 imaging interpretation patterns, and the criteria for diagnosing pulmonary embolism. This is a case of chronic pulmonary thromboembolism. Why? Because we look at the ventilation images, there is normal tracer uptake that is seen. In the perfusion, you have intermittent defects that is seen. So here also, we find that there are persistent defects that are seen. So these are the anterior images, these are the posterior images. So when there are defects, when there is a perfusion defect, it's related to the thromboembolism and other blood-related conditions. So radionuclides employed to perform the study we'll have to mention both the radio-labeled aerosols for ventilation as well as the nucleotide for perfusion scan. For ventilation, it is technetium-99 DTPA, xenon and chromium, while for perfusion, it will be technetium-99 macroalbumin, which is injectable. So the VQ ratio here, we usually obtain this ventilation with perfusion ratio, which we've all come across many times. So this is normally going to be about 0.8. If it is going to be more than 0.8, that's high VQ ratio. This is going to occur when the ventilation is exceeding the perfusion. So that is going to be reduced perfusion. So conditions related to the blood like cardiovascular shock or pulmonary blood flow obstructions will give us a high VQ ratio. While conditions with low VQ ratio will have a perfusion which will exceed the ventilation. So once again, conditions related to the lung. So which can be ARDS, pulmonary edema, alveolar collapse, asthma, and conditions like that. So it's better to have an idea about high VQ ratio as well as low VQ ratio and two conditions for each. So the imaging interpretation of this, that there are three types of defects like we know. One is a matched perfusion defect. This is when ventilation perfusion defects are the same. The next one is mismatched defect, which is commonly seen in conditions like veno-occlusive disease and any obstruction to the vessel. And the final one is reverse mismatch defect. So there's a defect in the ventilation in which where there is a normal perfusion. So there are three types of defects. Also depending upon the size, they can be more than 75%, 25 to 75%, or less than 25% defect. So coming to the modified criteria which is being used now for diagnosis of thromboembolism. One is the modified PI-OPED 2 criteria or the PSAPID criteria. There are other few criterions which are also used, but the commonly used ones are these two that are given. So moving on from the planar imaging to the more easier imaging technique in nuclear medicine. So that's a colorful image that's given of PET-CT. So here we have a 61-year-old woman who presented with history of progressive confusion, disorientation, urinary incontinence, and she has a history of surgery for a benign cerebellar tumor at 5 years of age. So what could be the interpretation? Right. So the questions are: enumerate the findings, list out any 3 commonly used radiopharmaceuticals, 4 disorders under this spectrum and their classical areas of involvement. So depending upon the areas of involvement, and 2 imaging signs. Once again, we have few signs, fancy signs in this clinical spectrum as well. So, so here in this image, we find that this is a normal uptake that is seen in all the areas of the cortex. But here there is an area of hypometabolism, like you can see in the posterior cingulate region or the parietotemporal region. So this is a hypometabolism in the parietotemporal region, posterior cingulate, and the precuneus region. So it's a case of dementia that we're looking at, and the commonly used radiopharmaceuticals will be FDG, fluorine 18 FDG, and we have amyloid PET, which is another new thing. So here we have 3 agents which we have to remember if there is asked even specifically. That will be fluorbitabine, as well as the flutemetamol. So these 3 agents are specific for amyloid and amyloid uptake. And we have the ioflupane SPECT, which is used for Parkinson's as well as Lewy body dementia. So the 4 disorders under this spectrum are, like we already know, Alzheimer's, dementia with Lewy bodies, FTLD, and vascular dementia. So we have different areas of uptake and cortical loss, hypometabolism in each of these conditions. In Alzheimer's, the cortical loss is going to be beginning in the temporoparietal distribution. In case of dementia with Lewy bodies, it will begin in the occipital lobes predominantly. In our case, it was in the temporoparietal region. And here in FTLD, like we know, it's frontotemporal. So it will either, the loss will be seen in the frontal or in the temporal. So we can actually narrow it down with the help of that. And in vascular dementia, we will be able to see strategic infarcts and multifocal areas of involvement. So these are the images here. So you can see the uptake with the help of this. So there is a hypometabolism in the temporoparietal region in Alzheimer's. In dementia with Lewy body, the occipital regions predominantly show hypometabolism. In FTLD, it is seen in the frontal region predominantly, and in temporal region also, there is going to be hypometabolism. So that can help us narrow down the spectrum here. The clinical signs that we will see is sparing of the cingulate gyrus, which was seen earlier in our case. So the hypometabolic area in the posterior cingulate region, that is a cingulate island sign. Reduced uptake can be seen in the putamen, specifically in the ioflupane study. So that is the period sign. So here we have an ioflupane study. This is a normal uptake in the basal ganglia that is seen. So that's a comma-shaped appearance which is seen. In case of Parkinson's, we will be seeing that there will be reduced uptake in the posterior putamen. So it will give us a period sign, which is otherwise a full stop sign. So that's the next case. So this is a 3-month-old infant which presenting with severe unilateral hydronephrosis antenatally. The rest of the renal tract is normal, so the scan has been given. So what is this study? I think all of us know it. Yeah. So the questions will be describe the findings, enumerate the different types of scintigraphy studies and respective pharmaceuticals, radiopharmaceuticals used, common clinical indications, the protocol for the scintigraphy and evaluation of renovascular hypertension. So the findings here, there's a sequential images, there are different phases for imaging this. One is the parenchymal phase, then the cortical transit, and finally the drainage phase, which will, this is a sequence of imaging for this. So the findings here at the 1 to 2 minute and the 2 to 4 minute images, so time is given over here. The left kidney shows lesser function, there's lesser uptake in the parenchymal phase in these regions. Then the tracer appears to move down much slowly from the left system than the right. And in the delayed images, there is persistent retention of the tracer in the in the left kidney. So this is a case of PUJ obstruction on the left. So the types of scintigraphy will be the dynamic renography and the static renography. So that is static renography is done with DMSA, while dynamic renography is done with technetium and LLE3, DTPA and MAC3. There are still 3 more types in dynamic renography, which is just dynamic, and if you have an obstruction, you can go for diuretic renography and captopril renography for renovascular hypertension. Common indications are going to be urinary tract obstruction, urinary tract infection, renovascular hypertension, congenital anomalies, renal failure, etc. So in case of the scintigraphy for renovascular hypertension, we'll look at the captopril, which has to be given 25 milligram orally or 0.04 milligram per kg of enalapril. The time differs. If you're giving an oral captopril, after 1 hour you will take the baseline. If it is enalapril, after 15 minutes we'll take the baseline. After the baseline, a repeat scan is done at 30 minutes, and the interpretation is when there is decreased the uptake and delayed clearance by the affected kidney compared to the baseline, then it is going to be a positive study. Also, if there is an exaggerated asymmetry between normal and abnormal kidney, that can be considered a positive study. So this is something that's very familiar to us. It's a PET-CT imaging. So this is the uptake here straight away. This is a case of neuroendocrine tumor. So where all do we find uptake? It is seen in the liver. There's some uptake in the retroperitoneal region as well. That's the last question. And we have to also know 3 somatostatin analogs. It's going to be used for SSTR PET-CT, which is somatostatin receptor specific. And also enumerate at least 4 physiological uptake sites and enlist 3 non-gastrointestinal areas. So here, as we've already discussed, there's avid retroperitoneal nodes that are seen. This is in the ileum, so it's a case of carcinoid with ileal uptake here. Also, there is hepatic metastasis that is seen. So quickly, these are the different NET specific agents, which is DOTA-TATE, DOTA-NOC, and DOTA-TOC. Physiological sites of uptake of this will be the pituitary, the salivary glands, thyroid, spleen, kidney and bladder, liver, adrenal medulla, as well as the bowel. Non-gastrointestinal indications can be neuroblastoma, oncogenic osteomalacia, and pheochromocytoma. Yeah. Thank you. Actually, there are more questions.
Thank you, ma'am, for that brainstorming session. I